Yeah, I was a little worried that me telling you to behave was going to backfire, but I appreciate it, and I won't be here next time, so it won't matter what you say. So thanks everybody. I'm really excited to be here to talk about MST very briefly, which stands for multisystemic therapy. And I know some of you have MST in your community just from my little breakout room. Some of you do not. So my hope is that this is just, an idea to familiarize you with it, if you're not. And then, if you're interested, contact me in getting more information if you think it would serve your youth and community well. Also, if you have MST in your community, my hope is that it just gives you enough of an understanding that it makes sense what's happening with the youth that we mutually serve. And I'm going to go ahead and screen share. And Mike, does that look okay?
Yep, it came up just like before. It's perfect.
All right, cool. So I am at Case Western Reserve University with Mike, as he said. I started doing MST right after graduate school when I graduated from Case Western Reserve University. And in my school field placement, I was a school social work intern and really started hearing about this great program that families were participating in. And I just like, this sounds too good to be true. What is this? And so ended up doing it right out of graduate school and have been involved with it over the last 22 years. And now I help programs to be able to be developed across the state and also to do clinical consultation and training with those existing programs. So MST is a very home and community-based program. We work in a really multi-systemic way, as the name implies, of our treatment model. So we are able to really quickly get into the different systems of the youth's life, but it's not us as the therapist doing that as much as we're empowering the caregivers of the child to be able to be primarily the ones running interventions with the idea that, we're building for sustainability. Because if we get in, work with a family and nothing's changed in the child's ecology, then things are probably going to just go back to the way they were as soon as we step out. So our treatment is completely individualized for the youth and family that we work with, and we really individualize it for their family values, the culture, the community that they live within. And so it's very tailored, session by session, intervention by intervention to the family's unique family that we are meeting with. So it's really for youth that are at very high risk of system consequences or already have experienced really, serious system consequences. That's usually our adolescents, 12 to 17-year-olds. They may be at risk or coming out of home placement and transitioning back to the home. They are often court involved, but not always. They're often having troubles in school to the point that they're, risking expulsion or have been expelled, etc. And then they're often involved with child welfare. So we can make exceptions for younger children, 10 to 11-year-olds. Once in a blue moon, there might be an 18-year-old that is willing to consent to this treatment approach that we would, consider on a case-by-case basis with the MST expert that consults with the program in the community where they are. So, as I said before, we have kids with externalizing behavioral issues, but they also very commonly have a lot of co-occurring issues as well, as the slide kind of outlines. And I apologize for such a dense slide set, but I figured I'll give the information to you and you guys can look through it if you'd like in more detail, but this is going to be a very quick, broad overview. So there are some youth that we're not an appropriate treatment for. And so youth that are living on their own and there isn't an adult who is willing and able to engage in treatment with us, then those youth are not appropriate for MST because we are so focused on the adult supporting the young person in our treatment model. And then also youth who have moderate to severe autism, youth who have profound intellectual impairment, or youth with severe homicidal, suicidal, or psychotic issues. And those with, severe mental health problems being the primary reason why they're having behavior problems, then we're not the treatment of choice for those children in standard MST. So we really try to work within our scope of practice, what the research says we are successful with and get good outcomes for, and we're definitely not, standard MST is not for every child's clinical needs. So we are supported at the Center for Innovative Practices as the network partnership for MST. So MST Serve, MST oversees everything that we do. They train and do consultation with us. And so then we're authorized to support all the teams around Ohio to do the work that they're doing in their communities. And CIP actually at CASE it wasn't at CASE when we started, but it was started with the goal of starting MST statewide and getting MST going statewide based upon some research and evaluations that was done in Ohio showing that, for example, the Ohio Department of Youth Services putting kids in there that had severe needs really wasn't addressing the underlying root of the behavioral problems, the criminal behaviors that they were engaging in. So CIP was started in 2000 to be able to expand MST across the state. And so we continue to work towards expanding MST statewide, but we have a really long way to go. And our state is hoping that we can be successful in expanding access to communities all around the state. So any youth who needs it can get access to the service, but we are far from that. But there's a couple of initiatives that are happening that we think are going to continue to be helpful. One being the federal legislation that passed in a bipartisan way back in 2018 called FFPSA, or referred to as FFPSA, which basically utilizes federal dollars to pay for evidence-based programs to prevent out-of-home placement for kids with severe needs. And then also, as you all know, I'm sure by now, OhioRISE. So those two things are working in tandem to support more MST programs to be able to roll out across the state. I just wanted to say quickly, so MST has the highest rating from the clearinghouse for FFPSA and in 2 domains for youth mental health issues and substance abuse issues. So that's why our state selected MST. And really just want to reiterate, because as we're doing statewide expansion and getting more referrals from Children's Services system because of FFPSA, it's just important for me to reiterate, I think, that it is not for kids that are at risk of out-of-home placement due to parental abuse or neglect of the child. It is for children who are being placed out of the home due to their severe behavioral issues. So just want to talk very briefly about, well, why do we do what we do and how do we do it? So MST has looked at the research over the last, 60 years to inform the treatment model. And so what we know is the #1 predictor for youth with these behavioral issues is who they hang out with. So MST works really, really hard to avoid putting youth in group treatments with kids who have severe behavioral issues, substance abuse issues themselves. We invest a lot of energy with the caregivers to try to direct them and steer them towards more positive peers, more positive activities. And so, our treatment is really designed to target what the research has shown over many years are risk factors for the behavioral issues that they have. But as I stated before, it's individualized to every child that we work with. So not every child has all these risk factors. And so our assessment is completely individualized to the child, and our interventions are completely individualized to the child. But the big goal is that if we can improve the family functioning, then we can help through that to improve what the youth's doing out and about with peers, what they're doing in school, what they're doing in the community, with the ultimate goal of reducing, eliminating antisocial behavior and improving their functioning. So we do that in a lot of different ways. And here's just a slide with some of the common interventions that we use in MST. And again, as I said before, MST really didn't create anything incredibly unique. MST is really a package of best practice interventions for youth with these risk factors that are super common for the kids that we work with. So again, what we use is going to be tailored week by week to what our individual assessment indicates would likely be most effective. And this is just a slide that talks about how do we address substance abuse behaviors. And again, it's not typically anything startlingly different from how we address other behaviors in MST, because that's what the research shows. It's not totally different approach to meeting the child's needs. And then we're able to do a lot of intensive interventions with families because we have really low caseloads with 4 to 6 families at a time for any clinician. And then it's a short, intensive treatment approach, like on average 4 months. And we have small teams, and we have a lot of supervisor availability to the therapists. And our on-call system is operated by the team itself. And so all the therapists on the team know the family's plans and know how to support that individual family if their primary therapist is not working at the time. I don't want to go too much into the research other than to say it's good, got some fantastic long-term outcomes. But again, none of that happens without adherence to the model and fidelity. And so I'm going to talk a little bit about what is that? What is the fidelity? So at CIP, we help do all the training and clinical consultation for the teams. And that goes on through the life of the program. And the other thing that's part of MST is our quality assurance, is we evaluate how the program follows the MST treatment model as rated by families every month. And we use that data and the outcome data to inform all the training that we do, all the clinical consultation that we do. And every 6 months, we put together a report for stakeholders within the agency and funders and referral sources so that they can see how we're doing and what we're working to have that continuous quality improvement. I'm not going to go over that. Just wanted to say a little bit about some of the challenges that we encounter, because we certainly do. As you all know, I'm not saying anything new to you guys, I'm sure, is that, we have obviously a massive workforce shortage in Ohio, and that is amplified just tremendously so when you look to be able to recruit well-suited, enthusiastic clinicians that want to get there in the home, in the community, work flexible schedule. Since the pandemic, it's become incredibly exacerbated, this ongoing problem that we've had. People want to do teletherapy. And so, when I started, it was really common for people to want to be in people's homes and, working flexible schedules and stuff like that. But it's become really, really acute crisis lately to get the workforce that we need to work with our youth and families that need our services. And one thing that can happen that can be a unique challenge for MST is, what we're asking parents and families to do is hard work in MST, and they sometimes can be vocal about their dissatisfaction with having to deal with this child, and they want this child gone. They can't deal with this child. They can't deal with this child. And it can be really easy for the system that works with them to be like, okay, we're going to place your child. We're going to take them out of your care. And so it's important with all of our system partners that we are kind of, holding hands and like, we can do this. We've got this MST therapist to support you. I know it's really tough. Let's try it. Let's give it a good try before we say that it's not going to work. That can be really important. The other thing that can be really important is referring youth as early as they need treatment, and not doing it as like, all right, they have 1 foot in ODYS. Now we're going to refer them. If they screw up one more time, they're gone. That's not helpful, because our kids do mess up. They're kids. It's a 3 to 5 month program for a reason. So it takes time for treatment to work. So those could be some challenges that we encounter out in the community that can be barriers to the program working well. But it takes time to also develop those relationships and trust in our treatment model that it can work if we work it. So we get good outcomes, and it's also important about how we talk to families about MST. So if you're in a position of making a referral, I just had a couple of slides here that can be really helpful about how we talk about the MST program. So, sometimes what ends up happening is people are like, oh my God, your kid has so many problems. Like, you really need help. We're going to refer them to this program. And then parents feel ashamed and like they're being blamed for their child's behavioral issues, which doesn't get anybody enthused about doing the work, right? So really trying to have a strength focused approach from the beginning to the end of treatment, and understanding that of course they want to give up, who wouldn't under the circumstances, but that we're here 24 hours a day to help them, and that we have that availability to work intensively to try to bring the stress down. And then, you know, it's a unique treatment approach in that it really takes into account what the families have to say. Every month they're going to be interviewed. We want to know what's happening, and we're going to use that feedback to inform training for their clinician. And they won't have to go anywhere else for services, except of course for like medication management. But we can save them money on gas and transportation because the clinician comes to them. The other thing that can commonly come up, parents are thinking, or referral sources are thinking, we can't work with this kid because they're uncooperative and they won't talk with the therapist. Our treatment model is designed for those kids. They don't have to be loving their therapist to get fantastic outcomes. So I include a slide here with some more information if you want. And there is also a video here if anybody wants to look at that to get an example of a case that's a little cheesy, but kind of gives you a sense of what it can look like. With that, I'll stop and see if anybody has any questions.